goal of this presentation is to show you some different images of supraspinatus pathology. An accurate diagnosis is not that simple due to the complexity of the anatomy and biomechanics of the human body. High-quality research shows that in plenty of cases, the diagnostic accuracy of the physical examination we do is limited. Currently, almost without exception, there is a lack of clarity with regard to whether common orthopaedic special tests used in physical examination are useful in differentially diagnosing pathologies. I can show you hundreds of different anatomical structures and even more pathologies, but let's keep it clear and simple. Let's just focus on a few normal, everyday pathologies of the supraspinatus tendon. On this slide, a healthy transverse supraspinatus is presented. Please memorise this picture. All patients in the cases you're going to see scored positive on 3 of the tests regarded as important supraspinatus physical examination tests: the NEAR test, the Hawkins-Kennedy test and the empty can test. You will see that although these patients scored positively on all 3 examination tests, the musculoskeletal ultrasound images appear quite different. This is a right side, most likely partial tear of the supraspinatus, which has resulted in intratendinous swelling. Hence the darker hypoechoic colour and increased thickness of the tendon. The tendon is 9.8 millimetres. The normal average is around 5 to 7 millimetres. So in this case, there's a big increase in tendon thickness which influences the subacromial space, resulting in subacromial impingement. The left side shows an old partial tear, which seems to be repaired with fatty infiltration. This influences the loadability of the tendon and thus the training load or therapy that should be applied. The bursa seems to be chronically irritated and the glenohumeral capsule appears to be swollen. All these specifics are important for clinical reasoning and completing the ICF framework. Is the empty can test a test with good diagnostic accuracy, capable of revealing all these specifics? Unfortunately not. This patient had a lot of pain on both sides, left more than right. Big intratendinous calcifications can be seen. Of course, these calcifications are not the only cause of pain, but they certainly interfere with the treatment. Patients will ask you, how long will it take for the problem to heal? How sure are you about your answer? Maybe you rely on the connective tissue repair phases, but then you presume that the complaint can heal totally. This is a young professional tennis player. He is right-handed and for the last 2 years he's been having increasing problems with his service. The ultrasound scan shows a partial tear which with training will most likely heal in about 6 to 8 months. The changes of the humeral head, however, are definite. These will probably permanently affect the mobility. This is the shoulder, a left-right comparison of a 73-year-old tennis player. On the left, you can see the asymptomatic side, and on the right, the painful symptomatic side. The right side shows a full thickness tear of the supraspinatus. The supraspinatus can't be seen anymore as it is already retracted. Apparently, the full thickness supraspinatus tear happened a while ago, after which retraction followed. As a result, the humeral head has migrated proximally due to a loss of active stability. Here you can see a left-right comparison of a 35-year-old carpenter. On the left, you can see the healthy, asymptomatic side, and on the right, the affected side. The supraspinatus on the right shows an increased thickness and a darker colour compared to the left asymptomatic side. This could indicate tendon pathology, a tendinopathy, or a partial tear. Musculoskeletal ultrasound can help in this decision-making. Here you see the shoulder of a professional gymnast. After 3 months of training, a perfect supraspinatus quality can be seen on both sides. At the right side, a minor bursa sheath thickening can be seen. This results in a tiny amount of friction with the acromion on active shoulder abduction. The patient was given advice and some exercises and we stopped treatment. In the previous images, you could see how ultrasound is able to demonstrate the specifics of a pathology more so than a clinical examination test could ever show. These specifics are important for your clinical reasoning and your therapy choice. But in theory, all these patients could have been asymptomatic. The findings could have been false positives. So to exclude these false positives, you will have to include your clinical examination tests. These are needed to see if the ultrasound findings are really clinically relevant. And of course, all information from the ICF domain, body functions and body structures should be seen in the broader context.